Good evening. My name is John Volpi. I'm a stroke neurologist and the director of the Eddie Skurlock Stroke Center at Houston Methodist Hospital. It's my pleasure to join you this evening for this webinar. Tonight, we'll be discussing PFO closure for secondary stroke prevention. This seminar is sponsored by Gore. The slides are my own and the thoughts are my own. In this presentation, we're obviously joining each other virtually, and we've heard throughout all these virtual conferences that we've attended how hard it is to be apart, that meetings like this are an opportunity to connect with friends and meet new colleagues and network and find out what everyone is doing. And it's not quite the same when we're joining virtually. I am going to include in my presentation some views from different parts of the world where I'll tell you I am now on this one at the Flagstaff, Arizona, on my way to the Grand Canyon. And you can see that beautiful vista. Other presentation slides will show parts that we've been for the reduced trial, and I'll highlight those as we go. But I think the main theme here is that we're looking forward to these virtual conferences being an opportunity for joining in the future, but live presentations being resuming soon. So with that, I'll kick off this webinar as a theme of the reduced trial. This is the 5-year data. And as I said, I'm joining you from the Houston Methodist Hospital. So just to remind us what was the reduced trial. The reduced trial was completed in 2017. It was a PFO trial for secondary stroke prevention. And at 2017, the follow-up was complete. At that point, the follow-up was a 24-month follow-up on the co-primary endpoint. What was the co-primary endpoint and why was there a co-primary endpoint? Well, the first part of the primary endpoint was what we would normally include in any secondary stroke prevention trial, freedom from clinically evident recurrent ischemic stroke at 24 months. But to push rewind just for a moment to remember the context of what was going on with the reduced trial, was there had been a recent negative trial of the closure trial. And as such, as the reduced trial was being planned, it was thought that a second co-primary endpoint of silent brain infarct should be included. That was either clinically evident or silent on imaging. In the end, the difference didn't matter, but that was the reason for having the co-primary endpoint. And here we can see when the trial was presented, the view from Prague, for those of you who are able to attend ESOC that year. This was 2017's site. Again, to remind ourselves what was the inclusion and exclusion criteria for the reduced trial. It included patients aged 18 to 59 years old. And that's an important part of the inclusion criteria because as we'll see, the results show a difference in age groups. It also was ischemic stroke defined as clinical symptoms more than 24 hours with an MRI positive. Again, in the context of prior trials, this was an opportunity to properly define a stroke using imaging criteria. Cryptogenic is more difficult to define and the definitions vary, but the definition used for the reduced trial was that there was no large vessel stenosis greater than 50% or ulcerated plaques in the intra or extracranial vessels. There was no atrial fibrillation or high-risk source of cardioembolism, and the stroke had to be non-lacunar. Also, the patient had to have no evidence of a hypercoagulable disorder and no other known cause of stroke. The medical management protocol for the reduce was somewhat different from other trials. There was no anticoagulation. It was an antiplatelet medical management. For the PFO, it had to be confirmed on TEE, and patients who had other medical conditions that would likely contribute to a high risk of stroke recurrence were excluded. And these would include uncontrolled diabetes, hypertension, drug abuse, or alcohol abuse. So what did the study show? So again, this is the 2017 results, which are likely familiar to many of you. And the curves are shown on the left and then zoomed in on that insert. And you can see the PFO closure arm had a leveling off of events for stroke risk recurrence, and the antiplatelet only group had a fairly linear event rate until about 24 months, and then there was a flattening of that curve. This was a particularly interesting outcome because we knew at that point that most of the patients were at the 24-month period. For the purpose of the study, a primary endpoint that had occurred beyond 24 months was still included if the patient was in the trial. So the mean follow-up for the patients was 3.2 years. When we see the PFO closure group separating from the antiplatelet group, the hazard ratio there was 0.23 or 77% relative risk reduction and a highly significant p-value of 0.002. Looking at the co-primary endpoints and the other efficacy outcomes here highlighted in the chart to the right, new brain infarct, silent brain infarct, recurrent clinical ischemic stroke, these broke down as being favorable for the top three, and the bottom one being silent brain infarct only without clinical events was not significant. But for all the clinically defined events and the ones that were apparent with without imaging was significant. So when the study was presented at ESOC in 2017, it was presented alongside other studies and published in the New England Journal around the same time as other studies. And then since then, there have been more PFO trials. And PFO trials can sometimes feel a little overwhelming in terms of the details and the different subgroups that were studied and the inclusion, exclusion criteria, what is an ESUS versus a cryptogenic stroke. And so I'm just going to summarize my own thinking on that as it has been evolving over the last 4 years since we saw the reduced trial results. And the two studies I want to highlight are probably the one that's on everyone's mind that's similar to the reduced trial would be the RESPECT trial. This was the RESPECT 10-year outcomes, which were published in 2017 as well. RESPECT was also a device trial in which the patients were randomized, but they were randomized 1-to-1. So in the reduced trial, they were 2-to-1. In RESPECT, they were 1-to-1. The devices were different. In RESPECT, it was the Amplatzer device. Ages were very similar, 18 to 60. And the mean age was actually nearly identical, age 45. One difference between RESPECT and reduced in the medical management is that the RESPECT trial allowed medical management with anticoagulation. And unfortunately, in the initial publication of the RESPECT trial data, there was dropout and crossover, which effectively decreased the primary endpoint power of the intention to treat. But by including a 10-year follow-up, they were able to increase that power and give a long-term follow-up intention to treat analysis with their hazard ratio of 0.55. And that's shown here on the right. And again, one of the things that intrigues me is not just the hazard ratio, but the curves. And here you can see in the RESPECT trial, the medical therapy group is fairly linear throughout the duration of the trial. There's a plateau there, but for the most part, strokes continued to occur in the medical therapy group and leveled off in the PFO closure group. The other trial is unfortunately similar name, completely different trial, which was the RESPECT ESUS trial. This was not completely a PFO trial. Again, the ESUS and cryptogenic stroke overlap, but are not identical. So for the ESUS population, this was a broader population that may or may not have had PFO. But the reason I'm including it is because it was one of these DOAC trials, which are informative in terms of medical management that had changed over the last 10 years. So for the RESPECT ESUS trial, it was a dabigatran 150 milligrams or 110 milligrams versus aspirin. It's a very large trial, 5,390 patients. And most of the patients, unlike the cryptogenic patients in RESPECT and reduced that were averaging age 45, these patients were generally over 60, or they had to have risk factors that enhance the likelihood of having things like atherosclerosis. Therefore, the mean age was 64 overall, but there was a pre-specified PFO subgroup, and even in that pre-specified PFO subgroup, the age was older, averaged 59 years old. And for that subgroup, I'll point out the N was 360 patients. That's important to remember because, again, the total number for the study was 5,390. So a subgroup of PFO positive of 360 is less than one would expect even in the general population, meaning that PFO patients were being underrepresented in this study. Nonetheless, it's one of the important trials for telling us about efficacy opportunities with the DOAC, and it did not show any efficacy and outcomes benefit for the DOAC overall or in the PFO subgroup. So if we look at that on the forest plot, you can see the patients who had PFO versus no PFO. There was essentially no difference between those who received the DOAC dabigatran or antiplatelet with aspirin. So my takeaways from the 2017 to 2021 trials was that the PFO device closure has been shown now in multiple trials and other meta-analysis to reduce the risk of recurrent stroke in select patients, and that anticoagulation, including the novel drugs, remains similar to aspirin in efficacy. For those of you who follow the practice guidelines from the American Academy of Neurology, in part, these studies led to an update in their practice advisory in April of 2020. And this was the takeaway point regarding device. In patients younger than 60 years with a PFO and an embolic appearing infarct and no other mechanism of stroke identified, clinicians may recommend closure following a discussion of potential benefits, such as reduction of stroke recurrence and risks, such as procedural complications and atrial fibrillation. With that background, we understand where the REDUCE trial played into the guidelines and played into our thinking on patient counseling. So the REDUCE 5-year data can add to that. What did the REDUCE 5-year study look at? It looked at freedom, the same primary endpoints, freedom from recurrent clinical ischemic stroke, but now up to 5 years, and incidence of new brain infarct defined as clinical ischemic stroke or silent brain infarct. This is an image of a place we were supposed to go. This is Vienna, Austria, where ESOC was planned, and we all wish we had been there. As with the initial study, the REDUCE 5-year included 664 subjects. It was, again, a 2-to-1 randomization in favor of device closure. And again, medical management was antiplatelet alone. There were 63 sites in 7 countries. And if you were following the New England Journal last week, you would have seen this as the brief report being published with these results. What was the follow-up that was capturing this? Well, follow-up was clinical assessment, which was performed at 1, 6, 12, 18, and 24 months within the primary endpoint, but then additional follow-up at 36, 48, and 60 months for the 5-year follow-up. The MRIs were done at baseline and 24 months. There was no subsequent MRI, and bubble study was at 1, 12, and 24 months. I should note there would be an MRI if the patient had an event, but there was no MRI required beyond 24 months for silent brain infarct. And our PI in Europe was Lars Søndergaard, and this is from Copenhagen, Denmark. I've never been personally, but a view that one might take in if you were visiting Dr. Søndergaard. So again, the 5-year primary endpoints were freedom from recurrent ischemic stroke and safety through 5 years. So what does the 5-year data tell us in terms of baseline characteristics? There was 11% crossover from medical management to device. So at this point, the patients received the primary endpoint results, and they were discussed with the patient in the context of whether or not that benefit would apply to them and whether they should go forward with closure. And 11% did cross over from the medical management to device. These are the baseline characteristics at 5 years. There's no significant difference in any of the baseline characteristics. And again, we'll point out, the 45-year average age in this study is, I think, an important one to keep in mind when seeing these patients. The 5-year primary endpoint was intention to treat, and at 5 years, the curves were very similar. There were 2 additional events. They both occurred in the closure device arm, and of those events, they were affected that hazard ratio, and it's now 0.31 at 5 years. That still remains a highly significant p-value of 0.007. And the annualized events now at 5 years would be for patients with closure, 0.39 per 100 patient years, and for medical, 1.26 per 100 patient years. As I pointed out with the earlier curves with the RESPECT trial, I think this is very informative and interesting, and I'm not quite sure that I have a simple theory of why this is occurring, but we did see an interesting difference between 0 and 2 years in the reduced trial. And again, the medical management arm appears rather linear, and the closure device arm, the red line, appears rather flat. And that shows the benefit at the 24-month period. But what's rather interesting about the 5-year follow-up is there seems to be stability. Beyond 2 years, in the 2 to 5 years, there was not a significant difference. So why is that? It may be some of the crossovers were able to contribute to less strokes. It could be that the disease is simply stable over time. But it's particularly interesting because that was not what we saw in the long-term outcomes of the 5 years. And so it remains an open question when we have one study that shows ongoing strokes and one study that shows stability. When we look at subgroups, these are very informative for telling us what we should be studying in the future. So the subgroup that jumps out at me is the one of age over 45. So if the average patient was 45, the breakdown being younger or older than that, what we saw was that there was a hint that there was an age effect in favor of patients being closed at an older age. And I'll use that as a plug for an ongoing study, which I'm proud to be the national PI for the REDUCE post-approval study, or REDUCE PASS. And the difference between REDUCE and the post-approval study is that this one is allowing patients up to age 70. So we'll be studying those somewhat older patients and seeing whether this age effect is as the same as it was in the REDUCE trial. Otherwise, the difference between male and female, the difference between enrollment location, the difference between shunt size, it's hard to really draw conclusions, as these were relatively low event rates. Even with the age, it's hard to draw conclusions because there were low event rates, which limit the subgroup analysis. Moving to the 5-year safety. Speaking of safety, this is my hometown, Houston, Texas, where it's shown with power. We were without power, as I think most of the country knew, and maybe part of the world, the energy capital of the world, as we like to consider ourselves. But the safety is important, and we all learned that. So this is the deaths. So death is the hardest of hard endpoints. And I'll go through each one so that you're familiar with all the deaths that occurred in the REDUCE trial. They were all captured in the first publication. There was one suicide related to depression, 131 days after randomization in the closure group. Also in the closure group, there was one fatal MI, 1,045 days after randomization, and one cardiac arrest on day 1,571. In the medical therapy group, there was one death due to hypertensive heart disease on day 1,383. As far as the 2 to 5 year additional follow-up, there were no late device fractures, there were no device embolizations, nor were there cardiac erosions during the extended follow-up, and there was no difference in DVTs or PEs. When it comes to safety, most of what we want to know is atrial fibrillation. So I'll discuss atrial fibrillation in some detail over the next few slides. The definition of persistent or permanent was part of the safety definition. In the closure group, there were 12 events, and that was a 2.7%. In the medical group, there was one event, and that was a 0.4%. If you're looking at those numbers and wondering how the percentages don't look the same as you remember the 2-to-1 randomization. So there were more patients in the denominator in the closure group. For any atrial fibrillation, the closure group had 30 patients, 6.8%, and the medical group had 1 or 0.4%. And as we learned from stroke AF, monitoring is important. And if you aren't monitoring many of these patients, you may or may not be capturing events. So no monitoring was required, especially in the long-term follow-up. When we discuss atrial fibrillation and when we look at it in comparison to other studies, it's important to remember that there are challenges with the delineation without monitoring, simply knowing whether or not a patient has AFib, and the analysis of that AFib when an event is captured, possibly in evolution. In other words, an event is captured at 12 months and these definitions apply, we may not know whether it's persistent paroxysmal or longstanding until more time passes. So what are those definitions? Well, paroxysmal means that it terminates spontaneously or with intervention in under 7 days and may recur. Persistent means it does not terminate in under 7 days. It often requires treatment to restore normal sinus rhythm, and it may have later paroxysmal atrial fibrillation. Longstanding means AFib for more than 12 months, and permanent means that it's a persistent AFib in which rhythm control is no longer pursued by the patient and their treating physician. So to summarize the overall differences between the 5-year and the initial median follow-up, which was 3.2 years, the stroke relative risk reduction was similar, 77% versus 69%. The procedure-related SAEs did not change and were 2.5% at the initial follow-up. The device-related SAEs were no different and were 1.4% at initial follow-up. The overall SAEs are listed, and the any AFib or flutter are 6.6% and 6.8%. And the effective closure rate, interestingly, increased as more time passed for endothelialization. So to try to encapsulate what does the atrial fibrillation mean, not only for the study, not only for the definitions, but for that message that you discuss with the patient, this I think is a helpful graph that was created by my colleague, Dr. Scott Kasner, and he's generously allowed us to use it today. And it shows the duration versus the onset of atrial fibrillation flutter. I'll let you take a moment to see those axes. So this is the AFib duration shown here, and the post-procedural AF onset, how long after procedure did it occur. And from that, we can say that 83% of AFib occurred early, if we'd say early was within 45 days. And most AFib, 59%, was brief, lasting less than 14 days. And there's a cluster of points here, and they're not all individually seen. So the takeaway that I often discuss with a patient, you're trying to, what's the percent, what's the likelihood, what's important, I often use this number, 2 to 3%. 2 to 3% had atrial fibrillation, which lasted more than 30 days. And it should be noted that at 5-year follow-up, there was only one additional AFib event between the 2 and 5-year follow-up. And that event was non-serious and resolved and was not related to device or procedure. When thinking about that patient in front of you, again, not the global impact of a study, but the N of 1, these are some predictors to keep in mind. Older males with prior stroke seem to be at the highest risk. Age per year imparted an odds ratio, additional risk of 1.09, and being a male imparted an odds ratio of 8.2. Having a prior stroke or TIA also increased one's likelihood with an odds ratio of 2.1. And I forgot to show, this is the Liberty Bell from Philadelphia, where our US principal investigator, Dr. Kasner, practices. So the big picture, what have we seen and what did we not see? This is where we were supposed to be for ISC this year near Denver. This is Crater Lake in the Colorado Rocky Mountains, where a wonderful hike to take and see. And if you haven't had a chance to come out for ISC, make a chance to do it in the future. But the big picture here is the benefit of closure persists for at least 5 years, a 69% relative risk reduction, and that's a number needed to treat of 25. There were no late device complications, and most of the AFib occurred early. So with that, I'll leave you with a picture of where we hope to see each other next year. This is New Orleans, where ISC 2022 is slated for, keeping our fingers crossed that we can all see each other on Bourbon Street.